Good.
Okay.
Yeah, your screen is visible. I think you start.
Okay. Good evening, everyone. I'll be talking about a retro approach, an approach which was tried some time ago to salvage the myocardium, but it has never gained momentum till now. In recent times, when the primary PCI is now a standard of care in ST elevation patients, and we more often than not face the issue of slow flow, no reflow, myocardial microcirculation injury during primary PCI. This coronary sinus approach, the backdoor approach to heart, has now regained some interest, and some recent trial data supports the use of coronary sinus occlusion techniques to reduce the infarct size and improve mortality in patients who are undergoing primary PCI, as well as those patients who are undergoing difficult PCIs which require cardiac support, and in some other applications also, which we will be discussing next. So all of us know, but we have never thought that venous circulation, actually the veins, coronary veins drain into the heart itself, but the arteries which are supplying to heart do not arise from the heart itself. So the veins are actually more close to heart, more close to myocytes, more close to myocardium than the arteries are. And there is no better option to reach the myocytes, to reach the cardiac cells, than through the venous system. So we have, if we want to reach the myocardium, we have the best option to reach the myocardium is through the venous system, because the veins, empty directly into the heart. So the nomenclature of cardiac veins was given by Ludwig-Gaussen. Most of the venous drainage of the heart drains into the coronary sinus. Coronary sinus drains most of the left ventricle except some part of upper septum. Most part of right ventricle drain into both atria and ventricles via lesser veins. Venous circulation outnumber coronary arteries by far number, means there is dense meshwork of venules around the heart, which allows us a direct access to myocardium. So our topic of discussion will be focusing on coronary sinus. Coronary sinus is the best gateway to reach coronary microcirculation and thus to reach myocytes. Coronary sinus sits in inferior portion of left AV groove, which is the position of coronary sinus. The diameter of coronary sinus is 7.05 plus minus 1.9 millimeter in patients with normal venous pressure, but it can be much more in patients with elevated pressure like right heart failure and in patients with pulmonary artery hypertension. The normal length of coronary sinus is 30 to 60 millimeter. A coronary sinus which is less than 20 millimeter in length is called a short coronary sinus. Both width and length of coronary sinus are important when we try to cannulate the coronary sinus, and when we try to use coronary sinus as a gateway to either place the electrodes or to place the balloons or to use coronary sinus anyway. So the width of coronary sinus, the venous pressures of the patient, and the length of coronary sinus are very important parameters which defines the future success of the coronary sinus cannulation techniques. So transcoronary sinus interventions in today's world has implications in treatment of microvascular obstruction and no reflow zones during primary PCI, in enhancing healing process of myocardial infarcts, in prevention of ischemia in elective cases like CTO, in high risk PCI needing cardiac support, treatment of high risk patients with diffuse CAD and ischemic cardiomyopathies, and the retro infusion of cardioprotective molecules and regenerative cells. So when we use coronary sinus to cannulate and to occlude it by balloon techniques, which we'll be discussing in some time, there is a silent zone of coronary sinus which is important. Whenever we cannulate the coronary sinus, we have to put the balloon in this silent zone of the coronary sinus. So what is silent zone? Silent zone is where there is no additional branching veins, where there is no additional veins which are inflowing into the coronary sinus. So it is relatively branch-free part of coronary sinus. It starts from inflow of posterior interventricular vein. Posterior interventricular vein is also known as middle cardiac vein, till the first branches of marginal veins. Marginal veins are also known as lateral veins. I'll be showing some images for that. So we have to first localize the silent zone of coronary sinus before cannulating it. Now there are valves in coronary sinus which can hinder cardiac catheterization of coronary sinus. There are two major valves. First one is Thevesian valve and second one is called valve of Huygens. So Thevesian valve is at the ostium of coronary sinus where it drains into the right atrium. So at the junction of right atrium and coronary sinus, there is a Thevesian valve. And at the junction of great cardiac vein and coronary sinus, there is a valve of Huygens. So for balloon occlusion techniques, we do not have to worry about valve of Huygens. We need to worry about Thevesian valve. Thevesian valve is sometimes thick and fibrous, and it can cause problems during coronary catheterization. When we use it for balloon techniques or for CRT or for infusion of cardioprotective molecules or for electrode placement in radiofrequency ablation. So if there is a thick and fibrous Thevesian valve, cannulation of coronary sinus can be very difficult. Another problem in cannulating coronary sinus is enormous back pressure, which can destabilize the catheter when we have once cannulated it. So there are different catheter stabilization techniques which are required. The operator experience is required to hold this catheter in place. So coronary sinus is covered with endocardial type lining which have embedded nerve endings, while great cardiac vein is covered with endothelial lining. Now there are some side effects when we cannulate coronary sinus because of embedded nerve endings in it, because these embedded nerve endings can cause reflex bradycardia and hypotension. So these are the potential adverse effects of coronary sinus occlusion techniques. So we have to keep in mind, we have to monitor the patient accordingly. Now there is a library, e-library on coronary sinus, www.coronarysinus.com, where studies on nomenclature of cardiac veins and important parameters like distances, angles, and landmarks to catheterize coronary sinus are available. So everyone should visit this website and try to understand the this venous anatomy of heart, the variation in the venous anatomy of the heart before trying to cannulate the coronary sinus and try to use the venous system of the heart for catheter interventions. This is the diagram I have made to simplify how the venous system of the heart looks like in LAO and RAO views. Upper one is the RAO view. So the silent zone of coronary sinus is from the middle cardiac vein entrance to the coronary sinus up to the marginal veins. Is my arrow visible?
Yes.
So yeah, this is the opening of coronary sinus into the right atrium. Here lies the Thevesian valve. This is the entrance of small cardiac veins. This one is the middle cardiac vein, also known as posterior interventricular vein. And some small veins called lateral or marginal veins enter into the coronary sinus directly. So the first marginal vein, from the inflow of this middle cardiac vein to the first marginal vein, this portion is called the silent zone of coronary sinus, where we have to keep our balloon when we are using this technique to for any purpose. So this is the RAO view, this is the LAO view. In LAO view, this is the middle cardiac vein entrance, and these are the marginal veins, lateral veins, and this will be the silent zone of coronary sinus. Now this is the venous phase of arterial coronary angiogram, which I have taken only 2 days ago to put the slides in. I have put some dots here. So this dot, this represents the entrance of middle cardiac vein, and some small lateral veins enter from here, not very nicely visible. So from this to this is the silent zone of coronary sinus. We have to keep our balloon here. This is the RAO caudal view, and this one is the LAO caudal. So now coming to the actual technique which is used and the pathophysiologic background why we are using it. So the technique which is nowadays getting practiced, on which a lot of work is being done, is called PICSO, which is pressure controlled intermittent coronary sinus occlusion. There is a device called PICSO which is made by a company, Miracle Medical. The PICSO impulse catheter is the catheter which we are using which we use for coronary occlusion techniques. The Pixo Impulse catheter is a 8 French double lumen catheter with a 15.5 into 20 millimeter long balloon at its distal end. This balloon inflates and deflates cyclically once deployed in the coronary sinus, leading to intermittent coronary sinus pressure increase. This catheter is connected to the console through two pneumatic tubes in which helium is shuttled to and from the balloon, not unlike IABP balloon. In addition, the coronary sinus pressure is monitored through the central lumen of the catheter. Now there is an algorithm which monitors the coronary sinus pressure, and according to this algorithm, the balloon inflates and deflates once the pressure threshold is reached. Once the pressure threshold is reached, it deflates. Then after some time, it again inflates, deflates, inflates, deflates according to the algorithm set. So what is the pathophysiologic background of this technique? This is useful for reversing, redistributing venous flow into the underperfused myocardium like a sloughing wavefront, allowing basal metabolism in deprived zones and expanding the vasculature during the occlusion phase. So when the balloon occludes, the venous flow does not get into the right atrium. There is a pressure built in the venous part of circulation. This increased pressure causes the redistribution of venous flow into the underperfused myocardium like a sloughing wavefront. When there is a microvascular occlusion, the small microthrombi are occluding the microvessels. So this pressure built up causes some distribution of flow into that part, which pushes the small microthrombi into the arterial side and allows the basal metabolism, because this venous flow is now available for myocytes to provide some oxygen, and some basal metabolism is allowed. So there is occlusion phase which causes this sloughing wavefront phenomena, and it expands the vasculature. Now because the blood is not coming out into the right atrium, the coronary sinus is occluded. So there is a pressure and volume built up into the coronary microcirculation, which expands the vasculature. Now this is what happens during the occlusion phase. Now when we deflate the coronary sinus balloons, there is washing out of edema which enters toxic metabolites and cellular debris along with it during the release phase, thus reopening new avenues for arterial inflow. So what happens during the release phase? Now the pressure has been built up, some blood has gone into the microcirculation which was previously occluded. Now the release phase, this toxic metabolite and cellular debris comes out, and the analysis of fluid which comes out during the release phase, the volume which comes out during the release phase is more than the actual volume which flows when we do not touch the coronary sinus. So this suggests that edema which was there in the microcirculation, edema which was there in the heart, is also getting reduced, because this flow which comes after deflating the balloon is actually more than what usually flows across the coronary sinus ostium. So edema gets washed out, toxic metabolites which causes reperfusion injury gets washed out, cellular debris gets washed out, and some of the microcirculation gets opened because of this. So these are the two things which we obtain during a primary PCI of ST elevation MI patients when we face no reflow or slow flow phenomena. There is another application of this Pixo technique, which is the stimulation of innate developmental pathways to initiate structural regeneration via mechanotransduction in venous endothelium. Sir, kindly excuse me for a minute. There is a call from casualty. I'll just kindly excuse me for a minute. Hello. क्या फेलियर में है क्या? सांस फूल रही है? अच्छा, तुमने भेजा है क्या इसी दिन को? होल्ड तुम तो अभी लेसिक्स दे दो उसको, बीपी ठीक है उसका, 40 mg लेसिक्स लगा दो, ज्यादा टेकिंग नहीं होगा तो बाइक पर लगा दो, ऑपरेट लेसिक्स दे दो और ऑक्सीजन लगा दो। अभी ऑपरेट हो गई है, फ्लूइड बंद पड़ेगा। अभी इतना करो, हम थोड़ी देर में फिर बात करते हैं। Sorry for interruption. So this was the pathological background of using this Pixo device in case of primary PCI and for some other regenerative purposes as well. So we have talked about the background, we have talked about the technique, we have talked about the device, but what is the evidence that this technique is helpful and reduces the clinical endpoints? So first in-man study of this Pixo technique was done in 1980s in patients undergoing CABG, and it showed improvement in regional wall motion abnormalities and infarct size and a trend towards improved clinical outcome. Although this was only a trend and it was not clinically significant, but yes, there was a trend towards improved clinical outcomes. This was in association, this was in patients who underwent CABG. Now, in patients who underwent thrombolysis in ST elevation MI, Miyazaki et al. Studied this coronary sinus occlusion technique and studied the duration between onset of IV lysis and culprit lesion reopening through clot lysis. And this duration was significantly shorter in Pixo group. So the Pixo patients, the clot dissolution occurred earlier in patients who underwent Pixo along with IV thrombolysis as compared to controls. Now, what is more important is the 5-year follow-up of this patient. Now, 5-year follow-up of this population showed 96% reduction for reinfarction and 86% reduction for major adverse cardiovascular events. And this reduction was, this figure was even after the correction for residual stenosis at 30 days and also for correction of difference in duration from symptom onset to reperfusion. So even if we, discount this shorter lysis time, even if we discount the residual stenosis which was there at 30 days, even if we discount all these factors, even after discounting all these factors, this 5-year follow-up of this patient, this population, showed 96% reduction for reinfarction and 86% reduction for MACE. So this, this finding developed too much of interest. Why? How it is happening? How this so much reduction in MACE, so much reduction in reinfarction is occurring even after correction of the primary events? So this has regenerated interest in the regenerative capacity of coronary sinus occlusion techniques, which has some pathophysiological background as well, which we will discuss. Now, another evidence for this is in Pixo in ACS study, in which 45 anterior wall MI patients in UK treated with primary PCI plus Pixo were compared with propensity score matched control cohort from Infuse AMI trial. So in Infuse AMI trial, the number of patients were 80. In this patient Pixo ACS, number of patients are 45. Infarct size was measured by cardiac magnetic resonance imaging. So infarct size measured by CMR at day 5 was significantly shorter in Pixo group, and there were no adverse major cardiovascular events related to Pixo intervention as such. So this intervention was safe and was effective in reducing the infarct size. There is another trial by Roberto Scarsini et al. 36 patients with STEMI underwent Pixo-assisted primary PCI and were compared with matched controls who underwent primary PCI. 72 patients underwent normal PCI and 36 patients underwent PCI with Pixo. Coronary microcirculation status was assessed using thermodilation derived index of microcirculatory resistance (IMR), and the vasodilatory capacity was assessed using RRR. And this infarct size and microvascular obstruction were assessed using cardiovascular magnetic resonance within 48 hours and at 6 months of follow-up. So there were 3 parameters, and all 3 of them showed improvement. IMR improved. The p-value was less than 0.0001. RRR significantly improved. P-value was less than p-value was 0.002. And infarct size and microvascular obstruction were also reduced. I don't know, this line has not come in this slide. There was an additional line. I don't know how it is missing. So infarct size was also reduced, and the index of microvascular resistance were also reduced. So So all 3 parameters, the index of microcirculatory resistance, resistive reserve index, and infarct size, all showed improvement in the Pixo-treated patients as compared to patients who underwent only primary PCI. Now there is a study which assessed the safety and feasibility of PIXO. The purpose of this study, RAMSES study, was only to assess the safety and feasibility. No major adverse cardiovascular events related to PIXO as such were observed in this study. They found that PIXO is safe in the setting of ST elevation MI, although feasibility was limited because of limited operator expertise. So the evidence which we have suggests that primary PCI, this PIXO is safe in primary PCI, and there is no adverse events related to PCI as such, as well as it is also effective in reducing the infarct size. Now, there was also a slide about regenerative capacity of PIXO. I don't know how that slide is missing. Somehow deleted that slide or what. So there is a pathophysiologic background how this PIXO. I'll come to a trial which, just a minute. Yeah, this 5-year follow-up of MACE. So this 5-year follow-up, when it showed this such dramatic improvement, dramatic reduction in reinfarction and major adverse cardiovascular events, there was a debate about how it is going to benefit in such a huge amount. So the pathophysiological, the physiology behind this, which has been explained, is the stimulation of innate developmental pathways. Now, what happens when the embryological heart starts beating at day 21? The embryologic ventricle starts beating. When the ventricle starts beating, there is a stimulation of gain of function mutation of genes which are responsible for myocyte development, and this stimulation of genes occurs because of beating of the heart itself. So when we occlude the coronary sinus, when we build up the pressure in the coronary venous circulation, this simulates this stimulation of innate developmental pathways, and which in turn causes gain of function, induces gain of function of genes which are responsible for myocyte regeneration. So this has been proposed as the mechanism behind long-term, benefit of PIXO occlusion, coronary sinus occlusion techniques. So this was all about the presentation part. We can discuss about it. Yes,
unshare your screen, please.
Just a minute, sir.
Yes.
Fine. Frank, your slides were not well organized because what I found, there some things what you are telling is missing. So that part, but what I could get is this retro approach, it improves the perfusion as well as it also improves the microcirculation, and by some genetic methods, as you are postulating, it improves the regeneration of the heart.
Yes,
we're following a myocardial infarction. In a nutshell, this is what you wanted to say.
Yes.
My one question is, if it is such an interesting thing, why not we are having a lots of trials on this particular issue? Why a very few? Because this is not a very difficult procedure.
Sir, actually the feasibility of doing it in a patient who has underwent ST elevation MI, there were some concerns that this using PIXO along with primary PCI will increase the procedure time. It will increase the time to open this culprit lesion. But with proper techniques which are now available, with proper hardware which is now available, actually this impulse device, PIXO impulse device, was not available earlier. Another thing was, when previously these occlusion techniques were tried, the occlusion was manual. there was no pressure control, and this manual occlusion sometimes overbuilds the pressure into the coronary venous system, and which has its own adverse effects like reflex hypotension in bradycardia and all those things. Now, when this device has come available in the market, it has come only recently, and therefore the trial data which we have is limited. Now, because there are concerns about the increase in procedure time of primary PCI, studies have been done in only limited subset of patients, and a lot of studies are now undergoing.
Dr. Guha made a comment.
Sure, Anyanda.
It's a very interesting experimental study, gradually becoming more clinical. But Shantanu, you will remember Sheila Kaur, one of the residents of the cardiac department, in 1984 or 85, like that, she went to USA, and we heard that hard subject of research is coronary sinus use in the background of ischemic heart disease. So that was the first time that we heard about coronary sinus blood coming to help the coronary arterial blood as well. Now, my question is that in the initial few studies, there were injury to the coronary sinus, and the results were obviously not very welcome. Subsequently, with the improvement of technology, you are trying to go for the exact amount of pressure that is created, the exact amount of blood that you like to steal out from the coronary sinus and go directly into the myocardial cells. And this intermittent control pressure study is becoming very important. And autoreceptor reperfusion. Do you have any idea what is that autoreceptor perfusions? They say that this is the latest methods and mechanical device that help perfusion of coronary sinus into the myocardium without raising too much of pressure or without doing any injury to the coronary sinus.
No, sir. I don't have idea about it.
Anyanda, can you enlighten?
So they say that this, we have been using all the devices. Initially, it was absolutely mechanical. We had to go by long time, was needed. And then there is an intermittent controlled coronary sinus occlusion. It is intermittent. And this intermittent, when it will occlude, when it will not occlude, will depend on the program setup. And this autoreceptor perfusion, I don't know much about it myself, but they say that this requires, the whole procedure is very simple and is almost, you can just switch it on, and with programming, it will occlude the coronary sinus and will release it. I don't know much about this method.
But if it is really, if it turns out to be true, in that case, obviously in patients with severe myocardial damage, you have some ways of giving some nutrition and oxygen to the jeopardized myocardium through the retro approach. That definitely this will be a boon, or rather a really beneficial thing, provided this this proves the test of time that it is really beneficial and it comes out in randomized controlled trials. Any postgraduates, and it's not postgraduates, all of you are DMs, rather any refresh DMs, any input on this particular thing?
One thing, Dr. Guho, you have rightly pointed out, this study, we came to know about it in 1984-85. That means about 35, 40 years back.
No, it was long back.
Yeah,
Actually,
so it's improving, but if it were really helpful, technically competent, and
in that case, we would have heard more of it.
We should have been hearing more about it.
And actually, this concept came from the surgeons. In patients with left main disease, very significant left main stenosis, the cardioplegia, they couldn't give it through the coronaries as they usually do. So they used to give it through the coronary sinus and infuse it so that it has an even distribution. And from there on, a lot of experimental things came up. as you said very, very rightly, this is, but what Priyank was telling, that in addition to the mechanical aspect, it also stimulates the genetic programming, which improves the regeneration of the heart. That is fascinating.
And another interesting is that we call CABG, coronary artery bypass graft, and there is a surgery here. This is CVBG, coronary venous bypass graft. So the CVBG is also an important small operation by which the coronary sinus can be controlled so far as supply and pressure is concerned.
Shaura, Shaumitra, anyone?
There's one question for Frank.
Yes, sir.
So is it reserved only for the acute setting, or you can do it in chronic settings also?
No, sir. There are many applications of it in difficult PCIs, like in which we need cardiac support, in total occlusions, in multivessel PCI, in which there is severely depressed LV myocardium beforehand. This coronary sinus occlusion techniques help in all those patients also. The data is limited. The randomized control data are limited, but studies are under, they are on the way in all these patient subsets.
Ovik, Somnath, Mani. We want more questions from you, man.
I think it's a very novel thing that we have
That's a
discussed
very
in this
interesting
meeting.
thing, yeah.
So the primary problem, the main problem behind using this technique is the availability of devices which are easily steerable into the coronary sinus in case of emergency like primary PCI, which can be done by obtaining a least amount of cardiac training. The learning curve should be small for the technique. So the primary hindrance behind this technique is the learning curve, the expertise needed to do it in such a timely fashion so that the opening of culprit lesion through the primary PCI is not delayed, and the cost of the device itself. So if these things can be taken care of, it can be used in the primary PCI in a larger number of patients.
What is the present cost of this device?
I don't know, sorry, I don't know even if it is available in India or not.
Shumanta, Spandan, any
Dr.
question?
Priyank, what made you take up the particular method of treatment of coronary artery disease to your liking? How did you come to know about and be close to it so quickly?
I was just reading a book, sir. I read it some time ago, around 6-7 months ago. So it just came to my mind that I can speak on it.
Right. Any question on this? Bhalo. Any question? Otherwise, we move to the next topic. Thank you, Priyank. Thank you very much for discussing this unique thing. It is a
Thank you,
totally new aspect of coronary intervention, and we expect to hear more about it in future.
Thank you for providing the opportunity, sir.
Welcome. Mukesh, Anjanda, did you say something?
I said this, Shida's সঙ্গে কোনদিন দেখা হলে ধরিস।
Mukesh.
Good evening, sir.
Good evening. You are prepared now? You can share your.
Yes, sir.
He is going to present a case of bifurcation stenting with complications. Mukesh, please. Share your screen or hung perhaps. সৌরভ কোথায়? সৌরভ? Okay. Mukesh, anything wrong?
You can go to share slide.
You share your screen. You are mute.
First, you unmute yourself and then share your screen.
क्या हुआ?
Sir, I'm going to share my screen.
Please. Right.
Sir, is it visible?
Yeah, it's visible.
But it is one of the slides coming from middle. Okay, fine.
Good evening, sir, and good evening, everybody. Today I am presenting a case of bifurcation stenting with a complication. This is a case of 71-year-old male patient, hypertensive, smoker, and dyslipidemia, presented with class 3 angina. Even patient was on optimal medical therapy. So initially, when I see this patient 6 months back, was class 2 angina. So I put that patient on optimal medical therapy, and at that time the pain was relieved, but gradually it required up titration of optimal medical treatment. So at the time of presentation, the patient was on aspirin, statin, amlodipine, and also 4 anti-anginals.
She is not diabetic.
Sir, excuse me, sir. Despite this, patient feels class 3 angina. So I plan to take the patient for coronary angiography. The vitals of patient: blood pressure 124/80, pulse 64, cholesterols are controlled, and sugars normal, and creatinine 0.9 milligram. So when angiography was done, sir, when angiography was done, there is this is angiographic picture.
Angio is not visible.
So it is not visual.
No, angio is not visible. Your slides are visible.
Okay, so I am trying to. Sir, it is visual.
Now it is okay. Now it is okay.
Okay. When angiography was done, he has minor plaque. When LCX have bifurcation lesion, Medina 111 at LCX and OM1, and LCX is dominant, RCA is non-dominant and normal. The angle between the two lesions is less than 70 degree, and the caliber of both vessels is almost equal. So I planned for Couillard method of bifurcation stenting. First of all, we cross the wires, both main LCX and OM1, and proceed accordingly. First of all, dilate side branch, then dilate main LCX vessels, and then casing balloon dilatation of both LCX and OM1. After that, bed preparation. I took a stent of 2.75/18 of drug-eluting stent to side branch and inflate it. After inflation, there is plaque shift and there is pinching of main LCX. So I have to again do the kissing balloon inflation, strut dilatation, and kissing balloon inflation. First of all, I have to recross the wire from OM to main LCX and then LCX to OM1. And so I do same things and do kissing balloon inflation. And this is strut dilatation step. And actually, after that, I remove the wire from the side branch and then deploy the stent in the main branch. And after deployment, this is also drug-eluting stent of size 2.75 into 20. And this is the result after deployment of second stent. So I have to cross the wire from LCX to SAD branch, and in colloid method, this is the most difficult step. So I'm crossing the wire from LCX to OM, and it is crossed. After that, we do strut dilatation, and my next plan is to do kissing balloon inflation. But when I try to kissing balloon inflation, the balloon is not going to side branch. And also in main branch, there is some difficulty to crossing the balloon. So I think there is some problem to wire entanglement, or there is stud maybe not fully dilated. So I think to first of all to proximal optimization of the stent so that it may create some space for the balloon. So I do the pot, and after doing pot, when I trying to do the kissing balloon inflation, the balloon could not go. So what can I do at this stage? So in my mind, it came that there may be the possibility of wire entanglement. So I want to remove the wire from the main stent, main LCX. And when I remove the wire and try to recross, then I take a shot. Then there is a acute thrombosis from the proximal end of stent, and patient is deteriorating, heart rate dropping, patient becomes bradycardia, and BP is also falling. So I immediately start noded support and doing temporary. And with temporary support, I again cross the wire to LCX and do balloon daughtering. And with balloon daughtering, then do intracoronary thrombolysis. And with export catheter, there is a thrombosuction. After all these methods, there is some flow comes in main LCX. So, but there is still there is no flow in side branch. So I have to save the side branch. So I further want to cross the balloon to the side branch, but it's not possible to cross. So I took a smaller balloon, 2.5 balloon, and meanwhile I check the LED. It is almost fine. There is no any thrombus shift or anything else to the LED. So finally, I took a smaller balloon of 2.5 size to the side branch and a bigger balloon to main LCX and do final kissing balloon inflation to save to hope to some saving of the side branch. So after doing the kissing balloon inflation, there is some flow come in the side branch. So at this stage, I feel there is some betterment of the previous stage. So I think that I can leave at this stage so that patient cannot deteriorate further. So I remove the wire and took a shot. There is a few thrombus at the osteoma side branch and at the LCX. So, and at the final shot, it looks almost okay, but there is some inadequate dilatation at the proximal end of the side branch stent. So I do not do further anything at this stage and want to end the procedure at this stage. So this is my case of bifurcation stenting. I think there is some problem in this plastic. First of all, there may be problem in wiring in the side branch when there is recrossing the wire after main branch stenting to when secondary crossing. There may be the possibility of a wire may go through the strut and not to the lumen, the main lumen. So this may be the one possibility. But I tried a lot, but wire go the same place. So this is my case.
Okay, thank you. Mukesh, please unshare your screen.
Thank you very much for coming out happy and healthy. And you managed it really very well, particularly the second half of the procedure. My question to you is that when you saw that bifurcation lesion side branch is big enough, so the first decision is that I should go for two-stent. Okay. Now when you go for two-stent, you decide the angulation is around 70 or 70, close to it. So the culotte or mini crush, these are the two supposed to be the choice of procedure here. But culotte requires a large, long proximal segment to accommodate.
Mukesh, unshare the screen. Let us see each other. Anjana, please.
Yes, sir.
So I think if you had gone for mini crush, it would have been probably better and safer. But you managed the second half of the procedure very well, and we must congratulate you for that. It was you kept your cool and did what is necessary exactly at that stage. That was fine. But before that, these are my suggestions.
Sorry, sir.
Mukesh,
My suggestion is that when there is a bifurcation lesion, the first I think that we should decide is whether the patient should take two-stent or it should be provisional main branch.
Sir,
This patient had side branch quite large, quite in both in terms of diameter as well as in terms of length. So that going for two-stent was the first right decision. Second decision is that 70-degree angulation between the main and side branch. That calls for two procedures, either mini crush or culotte. But culotte requires a little larger proximal segment. So I always love to go for mini crush. If you had gone for mini crush, probably, I don't say, would have been the right choice.
Sir, mini crush would be the right choice in this patient. But I try for the culotte because angle is less than 70 and side branch diameter is almost equal. So I think culotte may give a good result in this patient.
The only thing is that culotte requires a little longer segment.
Yes, sir.
Than what it had, this patient.
Yes, sir.
How much heparin you gave? There was a big thrombus.
Yes,
What do you found?
sir, it was adequate heparinization, sir. I checked.
Did you check during the procedure?
Yes, sir. Yes, sir. I checked. It is adequate heparinized, sir.
May I say something?
Yeah.
Sure.
Yeah, it was a dominant LCX. So, in my opinion, you should have put a temporary in place before starting the PCI. When you saw that there is a thrombus and you are operating on a dominant vessel, there are always chances of patient landing in bradycardia or AV block. So, a temporary should have been in place at the start of the procedure. This is what I feel.
Actually, I was taking the venous access already, so that I think that when complication comes, I put a temporary stent. So I already taken the venous access.
Mukesh,
It was a-
question. in side branch, I think the lesion is focal. It is not a long lesion in the side branch, and there is no calcification. So, in my opinion, I can also go for provisional in this, because initially I will go for a low pressure balloon dilatation in the side branch first, after doing two wiring, after putting two wires, and then I will put the wire in the main branch, and then we'll see the side branch. In that case, do you consider for provisional stenting? What is your opinion?
In case,
Because
in
it
this
is
case,
not
provisional
satisfying
stenting-
definition criteria for bifurcation.
Yes, provisional stenting is class 1 indication, and in this case, provisional stenting can be considered, but because LCX is dominant and there is a significant 90% lesion at side branch, so when we do stenting at side branch, there is high chance of compromise of main LCX. So we have
No. First, you will put first you do the side branch dilatation, low pressure balloon dilatation first, and then if there is a dissection, consider two stent. If there is no dissection, consider putting the main branch stents first. And if there is compromisation of side branch, then you can consider rescue stenting in the side branch.
Actually there is a
Pradeep,
significant-
Not satisfying definition criteria.
I just want to say one thing. That means you are keeping the side branch only a POBA and you are leaving it as such.
Yes.
If this is a big branch, I think that becomes a little risky. I think that becomes a little risky.
Antonu, this is what most of us follow. This is not a guideline method, not a guideline advice, but to play safe, this is exactly what Supradeep said. This is exactly what you do. Just open it up with balloon, and if there is no dissection or anything, keep it like this. Go for the main. That is not any guideline.
It can be done, not that it cannot be done. Definitely, many people do it, but if you see the long-term aspect, in that case, obviously there is a chance of restenosis is much higher.
Yeah, that is why I said you should first decide whether you should go for two stent or
Because
not.
we are not doing
No.
only the on the table at that spot. At that
No,
time.
sir. Restenosis only depend upon whether there is any gelled strut or not, whether there is any strut in front of the side branch or not. That is the main issue in case of restenosis.
Can
I comment on this?
Sure.
Satyen.
Satyen, please.
The indication of this revascularization is angina relief, right? It's not an MI.
Yes.
So we should always try to protect the side branch in this. First thing, we should not compromise with the side branch, because there should be some degree of residual angina if we leave the side branch like this. If it was an MI, then we could have thought for a provisional stenting and stented the larger vessel and salvaged the myocardium as much as we could. So it was an angina relief as an indication for revascularization. So we should try and protect both the branches. Number two, the sarc was a dominant vessel. So whenever we get two vessels where there is a main vessel and a branch vessel, we can define them by their distribution. So there comes the cross methods, because cross methods give you access to the main branch always. You never lose access to the main branch. So your chances of doing a successful PCI in these cases increases. So there should have been a planned bifurcation in this patient, because if we go for a provisional stenting, we pinch the side branch, then we have to recross it, dilate it, and put another stent in the side branch, which compromises the main vessel stent. And I don't think that both branches are of equal size. Those can't be equal size, because the sarc is a dominant vessel here, and he had 4 OM branches after that branch. So these could not be a same vessel size. If we can see angiography, these are similar vessels. We could have done for intravascular imaging to whether the both branches have equal sizes or not. So the simple to go in this procedure is to do a bifurcation stenting, a dedicated bifurcation stenting with a cross methods, so that the dominant sarc is always protected by our throughout the method. If we could have gone for a mini crush, whether a balloon to stent crush or a stent to stent crush, whatever you feel like, whatever you are good at, whatever you are confident at, and that could have saved all these mess. Because your problem started when you wired the side branch and dilated, and there was a dissection. You went through the dissection, and which caused the thrombus, nothing else. So if we could have stented the side branch first, because the sarc is a big branch, and it's a straight angle, you could never have any problem in recrossing it. So that would have been easy to go. This what I thought and what I have seen in the angiography. These are my opinions. But Mukesh, you have done a great job by salvaging this patient, because this was a viable myocardium, and sarc is a very notorious vessel, especially when it's dominant. It could have caused anything in this patient. A lot of arrhythmias, a lot of problems could have happened, but you have salvaged the patient. That's a great thing. Great job done.
I want to ask one question, Shotten. Do you think provisional stenting with kissing balloon dilatation at the end, is there any chance in increasing restenosis if there is no dissection and T3 flow in the side branch?
No. I am absolutely not. But no, absolutely not. But because we are trying to treat a class 3 angina with 4 or 5 anti-anginals, we should not compromise with the side branch also. That's my point. If it was an inferior MI with a proximal sarc occlusion or a whatever bifurcation, after bifurcation occlusion, whatever, and the patient has a residual 19% disease over the occlusion, I could have opened the sarc and left that OM, whatever it is, in its place. But it was a case where we tried to treat the angina, and both the lesions were significant. That's why I'm in favor of putting a stent in the OM, which has a large distribution area.
Shotten's he is very straightforward in this, and words are very well taken. Ovek, you want to say something?
Yes, sir.
Yeah,
First, Mukesh, it was an excellent case. The way you salvaged the patient, that was commendable. That is the most important thing. You brought the patient out of the cath lab alive. That is what is most important. Second, I also am in favor with, in line with Shotenda, that an upstream two-stent strategy is always better in this patient, in this setting, because of the initial overall picture. If we consider, I would also have gone for a two-stent strategy. But again, as Anjanal Dutta sir said, I also would have gone more in favor of a crush technique in favor of above the pull-up technique, because one thing, as Shotenda said, in crush, always the main branch patency and the main branch access is much more easier, which is of paramount importance because it's a dominant sac. And second, as Shotenda said, again, the culotte would not have been my first choice because of the disparity in the size between the two stents, two branches. And one thing I would like to ask is probably the hardware also caused a problem, right? The hardware must have caused some problem, as we all know. And that is also a contributing factor for, I think, thrombosis in this patient, I guess. Anyway, but overall, it was an excellent case, and the salvage was beautiful. Excellent salvage.
Yeah, any other comment, Mani?
Yes, I have some comments. Mukesh, I saw the case in details. The first thing is, as far as I saw, the OM had some significant lesion, but the lesion in main LCX at the bifurcation point was not that significant. So maybe there was an option for only POBA, as sir was suggesting, Dr. Dutta was suggesting. Maybe there was a chance, but if you are going for a stenting, then obviously provisional stenting is not a good option here, because in any case, whenever you are putting in a stent in the OM, the LCX is obvious to pinch, because by the anatomy and by the angulation, it was evident that whenever you will put in a stent, OM, the LCX will pinch. So obviously you have to take a dedicated bifurcation strategy if you are going at all. But I would rather suggest that in such cases, when this is the dominant LCX, a big LCX, a big OM also, you should take the help of an imaging before, whenever you are going for such a dedicated bifurcation strategy. The next very important thing is whenever you are crossing, whenever you have recrossed into the side branch after putting in the 2 stents, and you are planning to open the struts of the OM ostium and then do a kissing, in such situation, before opening the stent strut of the side branch, it is a dictum that you push in a balloon in the distal part of the main vessel, which you have not done. It should be done, because once you are opening the strut of the side branch, it will definitely distort the anatomy, and that can prevent your balloon entry, which exactly happened in your case. So wherever you are, even if you are doing a crush or a culotte, it is a dictum you have to push in a balloon into distal LCX and then open the strut of the OM. That would have saved a lot of mess. That is another important thing. Another tip I would give, that if you are unable to cross a balloon into the main LCX after you have opened the struts, it has distorted your stent anatomy, a stent strut anatomy. So there remains an option of a low profile balloon, which is now available. We call it Nick Nano balloon. It has a 0.85 millimeter entry. So I have faced such a problem in 2-3 cases, and where I could not even pass a 1.2 millimeter balloon, but I could use a Nick Nano in such cases to pass it across the bifurcation point. That is important thing. And lastly, when you have seen such a big thrombus, maybe you have successfully done everything, your end result looks decent, but I think you should have used an export catheter before finishing the procedure, because obviously you have seen there are a lot of thrombus. So when you have brought back the patency of both the branches, at least you should have done an export in the LCX. So these are some of the things I thought I should add with this procedure, but however, the end result was quite decent.
Any other comments? Anjanda, anything else you want to add?
So we have discussed all the possibilities.
Shomnath, you are there?
Yes, sir. No, it's a fine.
Any comment?
No.
I would ask Mukesh, how long before the procedure the patient had acute chest pain?
Sir, patient have acute chest pain around for 10 to 15 minutes.
On the day of PTCA?
Sir, during PTCA, when there is thrombus in LCX, patient complaining of chest pain.
How long back the patient was having? You just say you go for the angioplasty tonight or this morning. How many hours and how long back the patient complained acute chest pain?
Sir, chest pain increases last 1 week, sir. Last 1 week to 10 days, patient complaining of increasing chest pain.
Not any particular day?
No, sir, no any particular day.
So the thrombus that you came across at the end or middle of your procedure was not expected by you?
Yes, sir. Sorry, sir?
Probably you did not expect thrombus in such magnitude present at the start. That is why you are not prepared to take care of thrombus.
Actually, sir, I am considering of chronic stable angina.
Yes.
So I am proceed according to that. And at the initial procedure, when do I angio, there was no thrombus. And during procedure, there is sir, formation of thrombus, sir.
Shantanu, would you just tell him why did this thrombus become so prominent after some injury or anything? Because the thrombus was not there on the diagnostic angio.
That is, everybody has that experience. If you do some injury there, obviously you get a lot of thrombus, and most likely, as somebody was pointing out, there was a dissection and they again entered that part, and perhaps that created a lot of thrombus.
May I say something, sir?
Sure.
as Mukesh said that the chest pain, the history of chest pain was 7 to 10 days. So by definition, it is not stable
No,
angina.
no, not 7 to 10 days.
It is increasing.
It increased during the last 7 days. It
Even
is
if
not
it
7
increases
days.
in the last,
Old.
if recent onset increase in the intensity of chest pain, by definition, it was unstable angina. There is no other explanation except the vessel thrombosis for patient symptoms if the patient symptoms have recently increased. So
Not
there is this
necessarily. That can be an unstable plaque. There need not be an overt thrombus. An unstable plaque increases the reactivity and all. That also
there
can
can be
produce pain.
that there can be an
Yeah.
unstable plaque,
Yeah, that is
but cannot
perhaps
be
the
clear
reason why.
chronic stable angina.
No, patient was going for an unstable state. According to the history, for the last 7 days, his pain and other things increased. So perhaps patient was going for an unstable state.
Yeah, as Mukesh said that he planned procedure accordingly. He thought it to be a case of chronic stable angina and he planned the procedure accordingly. It was not chronic stable angina. Patient
And the
yeah,
main
patient-
issue is in his first shot, there was no thrombus. In the first diagnostic shot, there was no thrombus. Thrombus only appeared after he manipulated and he perhaps did some injury. So this thrombus is iatrogenic. We induced this thing. It was not there earlier. Because in that case, we could have seen it earlier in the diagnostic shot itself.
Sometimes thrombus is not easily visible on coronary angiogram, sir.
Quite
Thrombus
true,
is
but
there.
in this particular case, the thrombus was very obvious. So all of a sudden, you are getting a lot of thrombus. That means perhaps it did something.
It is a very dicey situation. Someone probably suggested export catheter or something like that to remove thrombus. I'm not too sure about it. This export catheter outcome is so
unpredictable.
It's so enigmatic. It may go distal, it may go proximally, it may migrate from here to here. And there are a lot of trials, the taste trial, all the trials have shown that there is no survival benefit with the thrombus aspiration. And our experience also is that unless you are sure that you have a localized thrombus here, if I go with the export catheter, I can bring it out, you should go. Otherwise, what you have done is excellent.
Siddhartha?
Yes, sir.
You suggested about that export. Do you really believe that we should have gone for an export in this case?
Yes, sir. When you can see such a big amount of thrombus developing in the proximal LCX, so there is this becomes a situation like an acute coronary syndrome. This becomes a situation like STEMI. So in such situation, the thrombus have every chance of getting, expelled into the LAD also. So when you are pretty sure about the thrombus, I think you should. It should be a thrombosuction run should be done because many times during primary.
Mukesh used a export catheter.
Yes, I used export catheter.
He used it, but what I could gather is you said at the end of the procedure, since there was some thrombus, you should again
not at the end, sir. Not at the end. Once he has stabilized the patient, given temporary and all those, and he has been able to recross the wire and again done some balloon daughtering, then before going for further kissing and everything, you should do an export because there is thrombus. And now when you will do a final kissing and pot, you will dislodge the thrombus either distally or proximally. So it's better that if there is any obvious thrombus which can be suctioned out, then I think that should be done, and then you go for the final kissing and final pot.
Actually, I do thrombosuction before final kissing because I need to open up the main LCX. So after all this procedure, main LCX was opened up after thrombosuction. But after that, side branch flow is not coming. So at that moment, I have to do kissing balloon to make sure that there must be some flow in the side branch.
No, that is fine. That is fine. You have done thrombosuction once before going for the final kissing, and still you were unable to bring a flow into the main, the side branch. Then you ballooned it again. That is fine. But that is what I was suggesting. You did not mention about the export catheter in your presentation.
No, he said. He discussed that thing. He said about the export. Any other issue anybody wants to bring up? Any questions, comments, or anything?
Only congratulations from our end. Finally making it look so
You did a
and
good job. That is you salvaged the patient very well. Though there initially regarding your initial steps, there may be some difference, and your selection of the procedure, there may be some difference of opinion, but ultimately you salvage the patient very well. That is what actually counts. And Beshotten?
Same here, sir. I want to congratulate Mukesh because I know where he is working, how he is working. So it is a place where you can't get things at your hand. You can't request for anything or everything. So he has salvaged the patient. That's the most important thing, and I'd like to congratulate him. And I would like to see him do such cases in the future also, and so was the cases here.
So for your information, Mukesh has shifted to Ranchi. He is now telling from Ranchi, not from Calcutta.
I know.
And then fine. He has joined a hospital there. Good.
And
Chandano's I'm taking leave. Thank you.
We will close it now. With giving thanks to everybody, to both the speakers and all the participants. Let us conclude it today. The next one will be after 2 weeks, and I will let you know who are the speakers in the next meeting. Thank you very much, and good night. Good night.
Thank you, sir. Thank you.
Good night, sir. Thank you.